Happy Halloween. There appears to be all kinds of treats at the front of the room for the people who are here. I'm sorry for the online listeners that they cannot participate because we could use your help eating everything by the looks of things. It is my pleasure to introduce Linda Pillsworth, who's the Manager of Environmental Public Health Services for First Nations Health Authority. Linda is a certified public health inspector holding a Bachelor's of Technology in Environmental Health from BCIT. She entered the field of environmental public health in the year 2000 with her first position in what is now Northern Health Authority based in Terrace. While that's too far north from some, having the opportunity to experience the beauty of the Northwest for 3 years was a privilege and offered a full set of challenges for her profession. Then she moved south again to work with Health Canada First Nations Inuit Health Branch in Kelowna, and then to Vancouver, where she spent 5 years in the Workplace Health and Public Safety Program of Canada. The last 8 years she has spent with the First Nations Environmental Public Health Services have progressively challenged her to lead the team of environmental health officers into a new organization with new opportunities and a truly more holistic view of environmental health. She believes that there's no one solution to improving conditions in First Nations communities. Rather, it requires the readiness and wisdom of communities, the support of health leaders, listening, learning, patience, and determination, and the belief that First Nations deserve an equal state of living as each of us do. Linda is supported by her husband and 2 boys who keep her busy while not working. Her current wellness goals are to stand up more, it is the new smoking, and to maintain her recent 10K running achievements. So we're very happy to have Linda here to talk to us about environmental health in First Nations. Thank you very much, Linda.
Thank you very much. And thank you very much for having me here. It's a wonderful opportunity to share our program with you. It's a very new organization that we have, and I'd like to first start off thanking the Musqueam First Nation for having me on their traditional territory. What a beautiful land it is here. So I'd like to first give you a little bit of an understanding of where First Nations Health Authority came from, because it is quite important where we've come to be, and this is we're a very young organization, only 1 year old as of October 1st. So why a First Nations Health Authority? So it's very important to recognize, if you haven't already had the opportunity to learn more about communities and First Nations health status, is that there's statistically significant health disparities that exist. Higher rates of suicide, higher rates of mental health issues, abuse, shorter life expectancies, a number of health outcomes that are statistically significant from the rest of non-First Nations populations. So it was very important to look at, why is that, and what are the root causes for that? And when we look at why disparities exist and how individuals can take ownership of their own health outcomes, it's very important that decision-making becomes closer to those that it impacts. So moving those decision-making about health into the hands of the First Nations is key in closing those gaps and improving health and well-being. The First Nations Health Authority is interested in transformative and not just incremental change. It's very important that we start seeing progress to start close those gaps. For those who you may know, is that a lot of the health services that the First Nations Health Authority currently runs were previously run by the Health Canada First Nations Inuit Health Branch. So some of the key factors of making change in a health services environment is that you get direction from communities and those people that it impacts rather than government. Policy and the programs should be developed for those who are going to be using it. The First Nations Health Authority also has an opportunity now to create partnerships where they previously did not exist. What has started the change to the First Nations Health Authority is an important key pieces of agreements that have started back since 2005, when the provincial government and leadership within First Nations in BC formed the Transformation Change Accord. And some of these important agreements, which are here on your slides and you can delve into further, are very important in that the provincial government and the federal governments recognized that First Nations needed to have a stronger role in the decision-making around their health services. And so that started to set out certain types of plans action items that needed to come in order to see some improvement in those disparities. So the mission of the First Nations Health Authority is to support First Nations individuals, families, and communities to enjoy the highest level of health and wellness. We work with them on their health and wellness journeys. We honor their traditions and their cultures, and we champion health and wellness. So it's not just about delivering services for them, it's by walking that journey with them and being that supportive network for them. In achieving the change that we are looking for, individuals and First Nations need to have ownership and control over those programs and that direction so that they can be healthy, self-determining, and vibrant. And we're not just looking at communities as a whole, we're looking at every individual within that community and helping to allow them to shape their programs and take control over their health. Some of the key directives, again, which you can look into further on our websites, is that we're community driven. We seek guidance from our communities rather than policymakers within the organization feeling like we know what they need. So it truly is about understanding what are the root causes in the communities, understanding what are the key challenges, and having them at the table in designing what we do. So again, I mentioned that we're very, very young. We're only a year old as of October 1st. And while these agreements and the plans to make this health authority have been years in the making, there's a number of steps that we've had to go through over the last 5 years in order to make the transition from a federal government organization to a nonprofit society that is receiving direction from communities. So we're going through a transition period of moving the pre-existing health services programs that used to sit with First Nations Inuit Health Branch, and those included programs such as nursing programs, early childhood development, dental programs, communicable disease control, health protection, and health surveillance programs, and moving those into the organization, and now looking at how do we transform them? How do we look at what we've previously had? Does it meet the needs of those communities? Are we actually seeing change? And if not, then what are we doing wrong? And seeking that guidance and feedback from communities on what that is. So we're well through the transition stage, entering into transformation. One of the key pieces that our organization revolves around is an important perspective around wellness. Wellness, when it comes to individuals, communities, and our environment as a whole, requires the work and the well-being of each of us individually. And so this perspective and vision of wellness is essentially focused at ensuring individually we are well enough and able to influence those that are around us. So the more well we are as individuals, the more able we are able to support our families, to support our neighbors, to support our communities, and our environment as a whole. Some of you who are very familiar maybe with the social determinants of health, I feel like this wellness perspective really incorporates a lot of those social determinants, which we need to look at more holistically. So understanding, what the land impacts are, what are the community, the cultural, the social impacts that can play into a person, a family, and a community's wellness. So again, this is the center of a lot of our initiatives, and everyone is a champion. We all individually within the organization have our own wellness plans. So we need to walk the talk, and there's a number of initiatives that you may have heard about. Beefy Chiefs is one of the common ones that I hear about, in that our leadership has taken on the responsibility that if we're going to run a health organization, we need to be well ourselves. And so there's a number of challenges going on between leadership, between communities to show that change can happen, and it starts individually. So First Nations Health Authority is the service delivery arm of what is the new governing structure within BC. So this is a very unique governance model for BC. We are the first and only First Nations health organization in Canada. In the remainder of the provinces, all of the services are still delivered either through the federal governments or through First Nations individually. So the First Nations Health Council provides policy support, leadership on the political side of things. The Health Authority, again, is the service delivery arm. And we work closely with the health directors in the communities. And what's very important is a tripartite committee on First Nations health, which includes the leaders of Canada, BC, and our First Nations in BC to ensure that this is a partnership moving forward and that it's not just the First Nations Health Authority assuming all of the obligations of each of those two governments. And essentially, it's a shared commitment. We're wanting to encompass physical, spiritual, mental, economic, and emotional, environmental, social, and cultural wellness, because all of these factors are important when we consider individual, family, and community wellness. And again, looking at the root causes. We can't find proper solutions until we know what are those root causes and issues that are causing those gaps. So again, Environmental Public Health Services formerly sat with the First Nations Inuit Health Branch. We were around for quite a long time, originally with the Medical Services Branch of Health Canada, and through some name changes, we've essentially been providing some of the same environmental health mandatory public health services to First Nations communities for probably over 4 decades. It is one of those federal mandatory health programs, and essentially the federal government has been running these programs and not the provincial government, because it has always been seen as the federal fiduciary responsibility to provide for the supports needed on reserve. Our environmental health officers are the primary health professionals that work with communities on environmental public health concerns with communities. We have 24 EHOs in the province. We are decentralized with 10 offices throughout the province to allow a more closer to community delivery of those services. As many of you know, we have over 200 First Nations communities in BC. Many of them are very remote, many of them are isolated, and so those present challenges when we're looking at how to deliver those services. The environmental health officers employed with First Nations Health Authority have the same professional designations as the provincial health authorities. We all require the Certificate in Public Health Inspection Canada. Our EHOs are then supported with a regional health office, with a manager of drinking water safety, environmental contaminants program coordinator, operations analyst, program officer, and additional administrative support. So again, an important piece to be aware of is the Constitution Act, which grants the federal government the exclusive jurisdiction over Indians and lands reserved for the Indians. And so this is why those programs have always been held with the federal government. An important thing to note is that because there are no federal regulations and laws that exist similar to what is in the province of BC, such as the Public Health Act. And that's primarily because the primary responsibility for healthcare rests with provincial governments, aside from the areas of on reserve, which has always rested with the federal government. So what's essentially happened with the First Nations Health Authorities is through a federal funding agreement, those resources that used to run the BC programs has been transferred along with a health planning process to this First Nations Health Authority to deliver those same services and to be able to essentially revise those programs to better meet the needs of the BC First Nations, as opposed to a lot of the decision making which previously happened in Ottawa. One of the important questions that many people have is, well, why don't we use the provincial legislation on reserve? And some of it comes down to in the fact that communities have a right to manage their own lands and to not be impacted by laws that impact their ability to hunt and to fish. So some laws, such as that are common application, criminal law and things like that, do apply. But when we start looking at land development regulations, safe drinking water legislation that attempts to control how and what you can do on your land, that actually impacts Indianness. And so that's why they don't apply right now. So what do we do in the absence of regulations? Well, regulations is not the only way to affect change. And in fact, in many cases, it's not going to affect change unless you have the awareness and understanding of why those changes need to exist. So essentially, our program stems around public health assessment, public education, and training. And with that goal, by changing behaviors, by creating that awareness and understanding of why one would want to change behaviors or do certain things in their community, there's an understanding of why and the importance to their health, to the health of their family, and to the health of the broader community. So our inspections and assessments, essentially we do inspections the same as regional health authorities would, yet this is an educational approach. We don't ticket, we don't order. Chief and council in the community have ultimate responsibility of what happens on their lands, and so we essentially are an advisor to those councils in how can they address the issues that we're seeing in their community. We do, however, use provincial regulations and standards as a minimum, so we try best to meet those similar and equivalent standards, higher if possible. So again, I mentioned education and the ability to enhance the capacity of communities, to empower them to, understand why there needs to be a change, having their ability to recognize risks and health risks in their community. And this is something that's not just a First Nations issue. It was an issue, when I worked with the province in a basic restaurant inspection. If the operator does not understand why they need to do what you're telling them to, they're not going to do it, and you're not going to see that long-term change. So it really is empowering the communities, individuals to effect that change. And again, that community involvement is very, very important. In our programs with communities, we sit down with them every year to understand, okay, what is your priority when we're looking at the environmental public health area? Is it drinking water, or do you have more significant issues in housing? Excuse me. And again, it's important that we respect their tradition, their culture. And as they walk through some of the program areas that we deliver, it's very hard for us to not look at that. And it's actually essential that we consider it in all aspects that we work with them. And much of our work often will be in looking at other players who can support that change, other ministries, other government agencies, other individuals within the community that can start resolving some of the issues that we might see. So again, our key players in the communities, chief and council, very important for them to have a good awareness of the conditions in their community. The community health director is essentially the individual within the community who has ultimate responsibility of health programs in their community. So First Nations Health Authority provides a certain level of funding to those communities to deliver their health services, and some of that includes funding for drinking water monitoring, and essentially they're the health rep for the community, the key person. The community health nurses, they're a very important person on the ground for surveillance of disease. So having that close relationship with them to understand whether there is an outbreak or whether there are certain conditions that might be causing a negative health impact to individuals. Health representatives are fairly common in communities. Again, they're a way to increase the capacity of the community to take ownership of their conditions and the work that's required in health, whether that's on a promotion or health promotion basis. Drinking water quality monitors are individuals that we fund to carry out drinking water monitoring within the community. They're the individuals within the community are the closest ones to their water systems. They understand where it's coming from, and the communities need to understand what the water quality is. So having someone within the community is very important. Obviously, the wastewater treatment plant operator is key. Housing managers play have a very hard role. in communities. And we'll get to that in the housing program as well. Community residents, of course, have their own role in health protection and taking their own responsibilities. And again, this ties back into that wellness model where really it is individuals taking ownership of what they can do. Circuit riders, these are supports provided under the Aboriginal Affairs Water and Wastewater Program that provides engineering support directly to communities and their treatment plant operations. Aboriginal Affairs in Northern Development Canada, so that's ANSI, a key role in funding for infrastructure within the community. Canadian Mortgage and Housing Corporation, and as well medical health officers, both as physicians that First Nations Health Authority employs in the areas of health protection, health surveillance, and health promotion, as well as maintaining relationships with the Regional Health Authority medical health officers who have the ultimate powers under the Public Health Act, should there be a health issue. So I'm putting some perspective to some of the community realities. Many of them are very remote. This is a fantastic highway to drive. Maybe not so much in this case. Gets a little bit treacherous. And the fact of the North is that if you need to visit a community, this is your only way in. That's reality. And this is the reality of some of the communities. They are isolated, they have limited access, they have small populations. And so it is a lot of, it is a huge challenge placing all the ownership of health programs and health services and running a community on such a small community in which it has such limited access to services. So keep in mind this perspective as we go through our programs. Currently, we've carried over the 8 core programs that we've held with First Nations Inuit Health Branch. These being drinking water, healthy housing, wastewater, facilities, solid waste, food safety, communicable disease control, emergency preparedness and response, and environmental contaminants. So I'll talk about drinking water first because it's probably one of our largest programs, largest funded. And for community water and wastewater systems, it's a partnership between the federal government of Aboriginal Affairs and Northern Development and what used to be Health Canada. And so Aboriginal Affairs and Northern Development would take on the funding role for the infrastructure and operation requirements. And Health Canada had that oversight role for public health verification of the safety of the water that is within the distribution system. The ultimate responsibility of the water system rests with Chief and Council and residents. So again, when we look back to that isolated community, we need to think of which one of those residents of 60 that they may have is going to be the water treatment plant operator. How do you train them? How do you retain them? Many who get trained, they're in high demand by the municipalities, and municipalities can pay them better. How do you bring in supplies? How do you bring in the expertise that you need to make those repairs when you need them? So it's a number of challenges in it. It's not just a simple fix as it would be for Metro Vancouver or some of the other very urban centers. We have a lot of water systems, obviously over 200 communities. Many of them are very, very small systems. And if you've had an opportunity to look at some of the challenges of the small water systems within the province of BC, you'll see the same types of problems within the First Nations communities. They're small water system challenges compounded by the isolation, the complex funding structures, being that it's funded through a government agency. To resolve some of the monitoring issues that we've had in the past, with monitoring drinking water in First Nations in any water system, you need to be able to get water samples for bacteriological analysis to a lab within 30 hours. And when you need to look at taking a flight, then putting it on a courier, and then trying to get it to Vancouver, it's just not going to happen. And so if you're going to go through the effort of doing all that sampling, you best to have information that actually means something. And so to resolve some of those transportation timeframe challenges, we started supplying the communities with in-community test kits, which is the call alert most probable number test. So this equipment essentially allows them to take a sample at a reagent using the defined substrate technology, and it actually, within 24 hours, can give them a result. So not only does this enhance their understanding of their water quality, it creates that ownership for communities as well. They are able to manage that. And then through those results, there's a reporting structure through our water tracks database and immediate reporting to environmental health officers if there is actual positive result. Advisories. It's always a big question around why is there so many more advisories in First Nations communities? And well, I don't know that there's that much more. When we look at it from a percentage of total water systems, we're running about between 25 and 30 approximately there each annually of drinking water advisories. And again, a lot of these advisories come off and on depending how the operations are functioning. And again, many of those drinking water advisories are in effect with those very small systems because, again, more challenges and many issues that you need to contend with. Microbiological quality tends to be our most common reason for advisories, and so often that is linked with things like inadequate disinfection and just the operation of the system not being able to maintain proper treatments. But generally, these are fairly consistent with the provincial reasons for advisories as well. Again, looking at that very small remote type of community, there's a number of challenges around how do you just run those infrastructure services and the human resources that are required to maintain that. So a number of challenges there, but again, a number of positive things that we've been able to achieve over the last 10 years, particularly since we've had a significant injection of funds from the federal government into water and wastewater. There are a number of very small communities with level 3 treatment systems with fantastic sand filtration and excellent operators. And so I really need to commend that because it's not all dire. We do have definitely a spectrum of the poor systems that still exist, but yet we have some of the best treatment plants out there that many municipalities are really pining over. So, I really have to congratulate the work of the departments of the communities in trying to see this change. And it really is a team-based response. It's not just any one person's responsibility. It's not just one agency's responsibility. And it's everyone coming to the table and trying to find those best solutions. So healthy housing is probably our second most important program area and where we spend an enormous amount of time in. And now on a day like today where, for those of you who aren't in Vancouver, it was just coming down in sheets, that is often the reality on a day-to-day basis for many of the coastal communities that are in BC. And the fact is, when you have so much water, you better have a very well-built house to keep it from coming into your house. So sometimes, when you don't have those effective, properly built homes, you do get water ingress into a home. And when those issues aren't caught early enough, the issues just progress and progress and progress. Some past studies have suggested that the on-reserve housing lifespan is approximately 7 to 15 years. So for any of us who have a house, it's amazing that that is really the short lifespan of many of the homes. And again, similar to drinking water, it's not just one issue, and it's not going to take just one solution to address the problem. Substandard building practices have been used. Oftentimes, some of the remote communities have a lack of trades and people to even come into the community and to build those houses. Sometimes there's incomplete builds. where you don't have your eaves troughs installed. And when you have that much water, those are pretty critical. To have effective drainage in the community to keep water from pooling around the foundation of the home. So all of those things need to be taken into consideration in building those homes. And when they haven't been taken into consideration, when there wasn't enough planning involved, it really just opens that home to a number of problems. Building materials are a huge factor, whether that's the type of roof, whether it's the type of siding, whether you're digging a foundation or you're laying a concrete pad. So a lot of those things need to be considered, and specifically on the location of where that community is, the type of environment. So definitely the West Coast environment is going to need something completely different than maybe Kamloops might have. Building inspection is something that hasn't been required in past builds. There is work to make sure that it is included now, but again, having that remote and isolated challenge is still something that's hard to overcome. The remoteness then means higher costs. So imagine that the West Coast community there that we showed. Imagine having to get building materials there on a barge, and that each barge cost might come to $40,000 just to have that barge there. So when you have such a small amount of resources to even draw from, that money just doesn't go very far. I briefly talked about the lack of skilled trades. And there's a number of partnerships that are happening now with the provincial government and Ministry of Labor to start building that capacity within communities to get them trained into building their own homes and retaining that skill within the community, because that is important not only when we're building the homes, but on an ongoing maintenance requirement. And then sometimes occupant practices can come into play. Things like smoking, wood burning stoves, housekeeping. Those are all factors that sometimes can come into play, which increase moisture content in the home, particulates in the home. Things like carpets are not something that we recommend in many of these homes, just on the basis of the simplest of things, like vacuum cleaners are not a common commodity. So it really requires some consideration to, what is the reality and what is going to be the easiest to maintain. So again, some of the key conditions that contribute to the poor health in communities is that water intrusion. Any way that water can get in will create problems unless it's caught early enough. Damp moisture conditions, physical hazards can happen as well. Any kind of entrances and decks and things like that. Of course, in those conditions, they are going to deteriorate as well, and that creates a safety hazard as well. One of the important things that we look at is susceptibility of occupants. Infants and children are extremely susceptible to those conditions, and those are hard situations to deal with, because of course the best thing in some cases for those families is to relocate them. But again, in such small communities, you may not have a spare home to send them to. So it's a significant challenge, and it requires that working with the community to find suitable options to get those susceptible individuals out of those conditions to protect their health. And sometimes existing respiratory conditions are a key factor into how someone will react within those conditions. Food safety, again, a common program for all of the regional health authorities, but I think the First Nations Health Authority really needs to take consideration of those traditional foods and the methods that are used. Traditional foods such as wild meat, game, moose, medicinal plants, the gathering, the different practices that typically don't happen in the urbanized populations anymore. And again, the different methods that are used. So the drying of meats and fish is still very common. Canning is very common, and again, in food safety, that's a key concern for us. Where how are they canning? Are they using high pressure canning where they should be? Many communities are still using boil water bath methods when, just because that's the way they've always done it, and they don't have access to the better equipment to achieve those high temperatures for the botulism spores. Traditional smoked fish, fermenting, particularly for roe, can still be seen. And this is one of those methods that really, when we look back to how they traditionally used to ferment roe, in holding the roe in a clay pot, covering it with cloth, burying it in the ground. And this allows an aerobic environment. It allows cooler temperatures. And so it actually limited the ability for botulism to grow. The current methods, which are, not the safer method, is, taking a yogurt container, sealing it nice and tightly, leaving it on your countertop, because of course that makes things work faster. Well, unfortunately, what that does is it creates that oxygen-free environment, and that perfect environment for botulism spores to germinate and produce the toxins. So unfortunately, there have been, over the last few years, sporadic cases of botulism poisoning because of fermented fish roe. And so, again, the importance of education and creating that awareness of, in this case, go back to the traditional way and find those ways to prevent these illnesses. Very basic facilities in many of these communities, if they do have a traditional hall or a kitchen for doing food preparation, very, very basic again. So we're not seeing the same type of commercial kitchens as one would in the regional health authorities. Awareness and education, those are very key. So again, the traditional methods, traditional foods are very important, particularly when we're looking at community gatherings and, again, respecting their culture, respecting their practices, and as much as, we'd want to find better ways for them to manage their foods from the food safety perspective, we really have to be cognizant of, of how closely they hold those traditions. Some of the common or other program areas include wastewater. So looking at on-site sewage disposal systems, community wastewater systems to make sure that they're not creating sanitation hazards, failing systems. Facilities such as community halls, playgrounds, those are common to have in most communities. And again, the community events can be quite large, sometimes up to 800 people when they have large cultural gatherings. And so, again, very important to have that education early on to make sure things like food safety, hand hygiene, proper equipment are available at those events. So communicable disease control, essentially, environmental health surrounds that concept of preventing disease and controlling disease. So all of our activities through inspections and assessments aim to reduce those risks. One of the key challenges in most of the provinces around First Nations data is that data is only accessible provincially through the medical services plans and those types of data systems, because again, as a provincial type of system that's managed, and in order to have access to that information, it just hasn't happened for us federally to have access to that, other than the 2 program areas of tuberculosis. So this is a bit of a challenge in that it requires that really close relationship with those health authorities who will get those case reports of enteric illnesses, and having that relationship to understand when there might be an illness happening, close communications with a community health nurse who may be hearing things from their community individuals. So we've had to look at alternate ways to get around some of those challenges. And essentially, it is important to have those surveillance functions to understand the burden of disease and have a rapid and effective response to outbreaks. So this is a key piece of work that our organization is trying to work on, because we really, in fact, don't have a good, solid handle on what is the burden of disease specifically within communities. Solid waste disposal, again, going to that beautiful community on the coast, which had a limited landmass. It's a struggle to find an area for proper solid waste disposal. Historical practices have included burning and other methods which just minimize waste. So again, it takes time to help those communities find alternatives. Takes time for funding agencies to find alternate methods such as barging systems and transfer systems to support those communities who don't have local options. A little bit simpler when we're looking at urbanized areas where they could make arrangements with local municipalities for solid waste pickup and recycling programs. Emergency response and preparedness is an area where we attempt to help communities plan in the areas of environmental health. What would they need to look at as far as communication protocols in the areas of water systems, wastewater systems, and should there ever need to be a reception center situated on reserve, we would be the health authority to provide those basic services in that area. And a lot of our work actually comes into play after the emergency has happened, whether it's a flood or a spill. Again, we're looking at, what is the impact to the residents, to the community, to drinking water sources, to food sources. And a lot of these emergencies don't just stem to your immediate environment, to your immediate community. So I'll have an example of that shortly. So, in these situations of floods, the second picture here is a realistic area of the depth of water that the flood came to. And the reality for this community, and it's something that just they've built a resilience for, is that this happens every 10 years. So it's not just a random act. And so it's something that, because the community has settled in that area and they have ties to that area and community, they're willing to adjust to this and manage with this because that is their traditional territory and the land which they're tied to. So in that same community, some of the mitigation measures has been raising that standpipe to that well. And in that specific flood, the water quality in that system never showed a hit of total coliform or E. coli, which was fantastic. So there are ways to manage. You just have to manage sometimes. The very recent tailings breach touched really strongly the communities in the area of Quesnel, Williams Lake, Indian Band, and Soda Creek. First Nations hold the environment very close to them, and whether they're situated immediately next to this tailing pond or whether this tailings pond is just in their traditional territory, it makes no difference. It still impacts them just as much because in this type of a situation, it's taken out a salmon nurturing creek that was very important to them. It's impacted the wildlife in the area. It potentially will impact the terrestrial environment. There will be ongoing impacts from this. And so, it's very important that while this might not have been an immediate impact to their direct community and their location, there's strong ties. And so we need to take that seriously. So this is an area where it is taking a lot of work, a lot of support by other First Nations communities. The concern for communities stretches all the way down to Lillooet and the Lower Fraser River, and that is because of the fear of this tailings is now in our Fraser River, and our salmon are swimming through that. So the ties are really close, and it's really trying to get enough information to understand what those impacts are, and in an attempt to hopefully reassure and hopefully there won't be such long-term impacts from this. Our last program that I'd like to talk a bit about is an annual call for proposals program that we call an environmental contaminants program. So this program, which formerly was with Health Canada also, had a regional and a national component and was aimed to help support communities in studying concerns that were of interest to the community, of concern to the community. And some of them relate to, you know, a fear of what might be in their wildlife that they consume, what the fear of the health of their fish, fear of, you know, what will happen to them if they eat that fish that they feel is contaminated. So again, it's community driven. They choose the concern. They follow through with the support of professionals to help them gather data and understand whether there is a risk or whether there isn't a risk to human health. And so, you know, many times data is what they need, and data helps for them to helps all of us to understand what those impacts might be to human health. So in these cases, it's very much a need for there to be a human health link. It's not an environmental monitoring program per se. There needs to be a link, an exposure link potential with human health. And so some of the common issues and areas of concern are traditional food safety, air quality, contaminants such as methyl mercury in lake fish, PCBs, PAHs, particulate matter, heavy metals, through a number of different foods such as wildlife, shellfish, medicinal plants, berries, anything that they feel that they consume enough that there might be a risk. So some of these, we run probably 8 to 12 projects every year, and it's an opportunity to ease some of those fears, help the community gain some understanding around what in their environment might be impacting them. A very important piece of work that was done in 2008, 2009 was called the First Nations Food, Nutrition, Environment Study, which was led by Dr. Laurie Chan, who at the time was with UNBC. And the attempt of that study, which was driven nationally with AFN, was to develop baseline information on the levels of contaminants in foods, in the environment, in water, to get a better understanding of what those risks might be, and good outcomes for that. We've used that information extensively over this last 2 months with Mount Poly situation. And on a positive note, the environment contaminant levels were fine. There were issues around food security, around nutritional levels within foods. And essentially, some of the conclusions were that the more traditional communities who eat more traditionally are healthier. And there is that reliance on the traditional foods rather than the processed modern foods. So that was a very important piece that came out of that. And as well, the food security issues sometimes are linked to the fears and the concerns around environmental contaminants. So in trying to resolve some of the direct health outcomes of, you know, things like rates of diabetes and things like that, it is very important to look at the traditional diet and, you know, make sure that that can be a strong component of communities and individuals. And something I frequently hear, and I think I hold really dear, and is that what happens to the land happens to us. And that's a very, very important viewpoint that I've learned. And, you know, it's a different way of looking at environmental health for sure. Much more holistically in consideration of all the different impacts there could be on health. So thank you very much. I'm very happy that you've invited me here and happy to take any questions you may have.
All right, I will run the mic. Oh, lots of questions. Let's go down here first.
Hi, Linda. Thank you for your presentation. Just a question. So the newer programs that have that are kind of been rolled out in regional health authorities, such as like Healthy Built Environment Program, do you guys have something like that in First Nation Health Authority, or do you guys have a specific team that's working on it? I know you've touched on healthy housing and food and stuff like that, but
yeah, we pretty much look at the healthy housing and that built environment in a similar way. things like radon is a new, well, it's not really new concern, but it is a very, very important concern that we need to look at. So while it's not a a completely owned program, we look at it in all aspects within the other program areas. So, and part of the transition into the new health authority will include a review of each of those program areas to look at what are we missing, what do we need to focus more on, what do we need to focus less on, because the amount of money that has been invested into water and wastewater, essentially what we're seeing is that there's not enough placed in housing. And that's, in BC, there's a lot of housing needs that need to be addressed.
I'm just going to ask a follow-up question. Can you contextualize the capacity of First Nations Health Authority compared with the other health authorities with respect to how many EHOs you have and how much staff you have to accomplish these things at a province-wide basis?
Oh. Well, I think from a facilities number, we definitely have less. Less, like, say, food facilities and those kind of things to look at. That being said, I mean, our housing program requires housing inspections prior to it going through any kind of funding process. And so that, I think that outweighs the fact that we don't have a lot of the public facilities. Travel, often some of these areas require 8 hours of travel. So definitely we could use more.
On the housing front, have you looked at using the factory-built housing rather than trying to do stick-built construction in these remote sites? You could barge in a factory-built home and set it up with a lot less labor and effort.
Mm-hmm, mm-hmm. Yes, and while, I mean, First Nations Health Authority doesn't manage that part of it, we do definitely, it is something that is considered in new builds based on location. But again, even some of those modular homes and pre-built homes need to still be looked at from, are they the right build for the location? So yes, in the sense that has worked, but again, the basics of, can your dock manage that house to come off of that barge, or is just the simplest of issues, which are not so simple in the community. So yes, and there needs to be a look at all of those.
Yeah, definitely you'd have to be custom designed and finished to suit the location.
Mm-hmm.
But yeah, it might be just from an economic standpoint, I would think there might be some big savings in doing factory-built homes that were, say, suited to a location.
There can be, but the problem is that the whole modern, our way of living is not at all the way First Nations have lived historically. So, as much as that's a possibility, I think we also need to start looking at, does it meet the needs of the family? The fact is, I mean, a lot of the families are much larger than any of us have. There might be 2 or 3 families living in the home. Are there enough bedrooms? Things like that. So it's an option, but may not be the option for every situation, definitely. So.
Also on the housing, is it at all feasible to use like more local resources instead of having to bring in everything, like use local wood, etc.?
Absolutely. I think in many cases where they are trying to build the skills in the trade, they're looking at what's within that local areas to support that. Again, potential to reduce costs. Some of them where they have access to timber and things like that, they'll go back to the traditional built homes. So it needs to be considered, definitely.
So I know like provincial health authorities use permits to know where like food establishments are and drinking water systems, and use databases like HealthSpace and Hedgehog. How does the First Nations Health Authority keep records of all these typically permitted activities?
Okay. Yes, definitely. We consider what is happening in other health authorities, and in fact use HealthSpace as our data system. And this transition has started happening over the last, I guess 5 years now, in order to better house that information. And some of it is in the attempt to, for the EHO user in doing their inspections. And then also it will be important when we start looking at what are the indicators within those inspections that might be able to tell us more around overcrowding, and what are the more frequent hazards that we're finding in those facilities. So definitely it is something that we're looking to get more relevant information out of those systems.
Over here. The experience with oil spills is that probably the most important health impacts are actually mental health impacts, and I'm wondering, in the context of the close connection with First Nations and the environment, that the sort of traditional paradigm of exposure to a contaminant to some specific physical health effect doesn't really apply or maybe not be as important as mental health impacts of kind of environmental degradation in general. So I just wondered if that's something that you considered, looked at, and how that's being dealt with.
As an organization, we definitely are looking at crisis in general much more broadly. We're not just looking at it in the sense of floods, fires, spills. It is also looking at how crises such as suicides and deaths in the family, things like that, impact the mental health and well-being of the community. So, definitely when there is a disaster that happens, bringing those supports into the community is very important. And I think one of the bigger challenges is how do we monitor and look at that over time and the impacts. That's a very relevant question I have in regards to the potential socioeconomic impacts of, say, the mine tailings breach, because as much as it depending on what the outcomes are as far as the human health risk assessments and ecological risk assessments, you still do need to consider the mental health component.
Linda, question here. Thanks. The timing of your presentation actually is great, because yesterday I attended a webinar given by Dr. Trevor Hancock, and he spoke about health equities or inequity in Aboriginal peoples. So one of the slides that he showed illustrated very remarkably that housing considerations is at the top of the issue list for Aboriginal peoples. And given the number of questions surrounding housing today, it's no wonder a concern. So my question is, does the First Nations Health Authority work closely with the Canada Mortgage Housing Corporation? And if so, what might be the top priority areas to try and address some of the more difficult, challenging issues faced by First Nations people in BC?
Very good questions. Something that we need to look at in a strategy, a long-term strategy, definitely. The aspects of other organizations, we definitely do work with CMHC. They fund a certain category of homes within communities, so they are one of the funders for that. And again, some of the issues is around lack of money to replace and rebuild a lot of these homes, particularly where if you start having mold issues, you're now doubling the costs of remediation. So from one of my feelings is that we really need to enhance the housing programs within the communities to better maintain those homes, have those fixes earlier on before they turn into major renovations, because I think that'll serve to save costs, to again build the capacity of the community to manage those repairs on their own. And the fact is, residents don't own their homes, so it's no wonder that there isn't the same attention and care placed to them. There's a lack of feeling of ownership. So it's a concern, and definitely requires kind of all those players to be involved. When we see significant health issues within a home, that kind of triggers our more closer working with Aboriginal Affairs to make sure that that home is actually on the radar for future funding and targeting, just to make sure that if it is an issue of lack of community capacity to bring it to the forefront, then at least it's on the radar, and those extra supports can be offered.
Okay, we are right at time, so thanks again, Linda, for this great overview of what's happening.
Thank you very much.